and 12-year-old girl is brought to the emergency department due to right shoulder pain. The patient first noticed the pain 4 days ago after softball practice. She has been placing cold compresses over the shoulder and taking acetaminophen with initial improvement, but the pain has awakened her from sleep the last 2 nights. Today she is unable to lift her right arm to brush her teeth. 4 months ago, the patient was diagnosed with polyarticular juvenile idiopathic arthritis involving the wrists, knees, and ankles. She is taking methotrexate, and her symptoms had been gradually improving after dose adjustments. Temperature is 38.5 degrees Celsius, or 101.3 degrees Fahrenheit. The patient holds her right arm at her side, and she resists attempts to move the shoulder due to pain. The overlying skin is warm, bilateral wrists, knees, and ankles are mildly edematous. The shoulder joint is aspirated, and synovial fluid analysis reveals leukocyte count of 55,000 WBC m cubic meters, with 80% polymorphonuclear cells and 20% lymphocytes. What is your differential diagnosis? This patient's history and synovial fluid analysis are indicative of septic arthritis, a bacterial joint infection. Juvenile idiopathic arthritis, or GIA, is a risk factor for septic arthritis because underlying joint inflammation predisposes to bacterial seeding. In addition, patients with GIA often require treatment with immunosuppressants, as in this case, thereby increasing susceptibility to unusual pathogens. GIA management may also include intra-articular injections, which potentially allow direct inoculation of the joint space. Recognition of septic arthritis is frequently delayed in patients with GIA because new onset joint swelling may be attributed to a GIA flare. However, an atypical flare of a single joint should raise suspicion for an infectious etiology. Red flags include severe, acute pain, often leading to nighttime awakening and refusal to move the affected joint, as seen in this patient. Fever is also typically present. Joint aspiration should be performed for suspected septic arthritis. Elevated synovial leukocyte count greater than 50,000 per millimeter cubed with a neutrophil predominance, in other words. Polymorphonuclear cells 80% to 90% is highly suggestive of infection, and identification of bacteria in the synovial fluid is diagnostic. Treatment includes immediate antibiotic therapy to prevent permanent joint damage. A GIA flare typically presents with insidious onset of intermittent joint pain, swelling, and morning stiffness. In addition, synovial leukocyte count during a GIA flare is typically less than 50,000 per millimeter cubed. Adding a virologic disease-modifying anti-rheumatic drug, increasing methotrexate dose, and administering intra-articular glucocorticoids are GIA treatment options. This patient's acute onset of severe, worsening pain causing nighttime awakening and synovial fluid analysis are concerning for septic arthritis. Nonsteroidal anti-inflammatory drugs and rest are treatments for musculoskeletal injuries, for example, rotator cuff tendonitis, bursitis, which typically present with pain exacerbated by shoulder movement. Severe pain with nighttime awakening, fever, and elevated synovial leukocyte count would not be expected.